I'm going to talk about renal artery intervention in the treatment of fibromuscular dysplasia and tell you about some concepts that are not entirely true, but I hear repeated time and time again. So as you've heard, there are two major types of FMD. There's multifocal FMD, the so-called string of beads, and there's focal FMD, a focal area of narrowing. I can't give a talk on FMD without showing this, because this is the best and most characteristic appearance of fibromuscular dysplasia of the renal arteries. You see beading in the mid and distal part of the renal arteries and its branches, whereas atherosclerosis occurs in the proximal part of the renal arteries. Now, this is the focal type, and there's two ways that this looks, and they're treated differently, multifocal and focal. This is like a focal, very severe narrowing in a 28-year-old. And recently, I've seen 3 men in their 50s with this type of focal FMD. This is tubular stenosis. And the difference between this and multifocal is the cure rate with intervention with this is much higher than the cure rate is with the multifocal type. And if you take individuals such as this gentleman, who I just saw yesterday, you can see we put a stent in him. Now, I know many patients come in and say stents are not indicated in FMD, and for the most part, for the string of beads type, they're not indicated. But for focal FMD, sometimes you have to use a stent. And it's okay, but I'm going to show you some examples where it's not okay to use a stent. And then in this guy, we imaged his carotid arteries, and you can see the characteristic S-curve or significant arterial tortuosity. So both focal and multifocal have abnormalities in the arteries, not just in the kidney or the head. And patients with spontaneous coronary artery dissection also have an appearance like this. This was a 16-year-old I saw. This is his left renal artery. And this is his right renal artery. Look at this, a long area of narrowing. He was treated for 4 years as having vasculitis, Takayasu's arteritis. And he was on potent immunosuppressive agents, and it clearly was the wrong therapy. There was no evidence he had an inflammatory vascular disease. And as you can see, that left renal artery was stented. When you see lesions like this, you almost always have to put a stent in. And so he came to me with stents in both renal arteries already. And the problem is the stents kept re-narrowing. And that's why you have to be very careful when you're putting stents in renal arteries of young people with fibromuscular dysplasia. So here's an example of one of the problems that can occur with stents. You can see the stent here, and then you see a very thin column of blood through that. And this area of the stent that's not filling with blood is called intimal hyperplasia. It's a response of the body to injury. So when the stent is expanded, it causes an injury to the arterial wall, and some individuals respond by this intimal hyperplasia. When this happens, you have to do a re-intervention on them. And there's a lot of different things that can be done. I'm not going to go into the technical aspects of it, but it can be treated if this happens. Now, the group from Paris showed that there's a major difference in the way people with focal and multifocal FMD present. So if you take focal FMD, the average age of onset of hypertension is 26. The average age of onset of hypertension in multifocal is 40. There's a 4-year delay in the diagnosis of focal FMD from the time of hypertension until it's diagnosed. There's a 9-year delay in patients with multifocal. So we know that the shorter duration of hypertension before intervention, the greater likelihood of cure. So focal patients, 90% of them underwent an intervention. They had really severe marked decreases in their systolic blood pressure of 30 millimeters of mercury and diastolic of 19. So they had normal blood pressures on no medications. Multifocal FMD is different. They've had high blood pressure, many of these patients, for a very long time. So most patients who undergo an intervention do it because the blood pressure becomes difficult to control. And the cure rate with this is not even close to what we see in focal. In fact, if patients are just treated with an average of 2 drugs, on the whole, you can get the blood pressure normal. You can decrease the systolic by about 20 and the diastolic by about 14. So the indications for multifocal FMD are different than the indications for focal FMD. Now, there are certain misconceptions that you can tell how severe narrowing the artery is by looking at it, that you can tell how effective your angioplasty is by visual inspection, and that because stents are the norm for atherosclerotic renal artery disease, they should be used in FMD. All of these are false. Here's an example. Look at these 4 images. And if someone reports that there's a 70% stenosis of a renal artery here, you know they don't understand FMD. They don't understand the disease at all. You can't tell which of these are the most severe. I would suggest that this one up here looks mild and that this one looks pretty severe. When we do pressure gradients, we measure a pressure with a pressure wire here, and we measure it here. And the difference in this case is 50 millimeters of mercury. So if their blood pressure was 140 here, their blood pressure here was 90. And that tells you that you have what's called a hemodynamically significant narrowing of the renal artery that needs intervention. So what about treatment? If there's no hypertension and normal renal function, even if you have FMD there, you just monitor kidney size and follow clinical parameters and do head to pelvis imaging. If you have recent onset hypertension, intervention is an option, a good one, and the chance of cure is very good if the hypertension was relatively recent. Any hypertension longer than 5 years, you're not going to get a cure. Or if you have poorly controlled high blood pressure or impairment in kidney function, then you want to do angioplasty of the renal arteries. Stenting is usually not indicated, but this is not absolute. The only times to stent for multifocal FMD is if you cannot obliterate the pressure gradient, or if you cause a renal artery perforation, a hole in the artery, in which you need to put a covered stent in to cover the hole in the artery. I'm not going to go over the technical aspects of this, other than you should do an unstimulated translesional gradient of the aorta to renal arteries. Let me see something here. Is that better, Pam?
I can still see the whole PowerPoint. That's okay. So,
Okay.
In mine, I went up to presentation and the slideshow is what I did, but it's fine.
I can't do that. It'll show on the other screen and you won't see it.
Yeah, so that's okay. We can see it.
All right. This is optical coherence tomography. This is a catheter inside of the artery. This is the size of the artery. And as we move on, I'm going to show you what happens in people with FMD. So you're going to see the artery getting bigger and smaller, and you're going to see webs inside of the artery. Okay, you see the artery is getting smaller around the catheter. It's getting bigger again. bigger. And you see a web right there. This is a web in the artery. We're going to see a dissection in the artery there in a minute. These are things that you can't normally see. Look how big it's getting. Now it's getting really small. Now it's getting big again. It's small. You're going to see the dissection over here, very small. And boom, there's the dissection. So this is what you can see. We don't do this routinely, but this is what you can see on optical coherence tomography. Here's an example where there's a pressure wire here and pressure wire here. And you can look at this and you can see that the pressure here is 160 or 170 and the pressure here is 120. So this tells you there's a major pressure gradient. And when you do an angioplasty, you want to make sure the pressure gradient is obliterated. This just shows that the older you are, the less likely you are to have a cure of high blood pressure. And that's because when you're young, you probably have focal FMD and you probably have had it for a very short time, and the cure rate is about 90% or so. Now, here's a perfect example of what I'm talking about. This woman has a tubular stenosis here. She's 26. She had high blood pressure since she was for about the last 6 months, and her cardiologist picked it up very early. This renal artery looks normal. So we did an angioplasty, and this looks pretty good. So we come back, and you can see here that it really looks quite normal. We routinely do pressure gradients on arteries that look normal. And when we put a pressure wire across this, you can then see this lesion here, and there was actually a 50 millimeter mercury gradient. So had we not done this, her blood pressure would not have been cured, and we would have thought angioplasty was a failure. But we did an angioplasty of both renal arteries, and she had a cure of high blood pressure. It's now been about 13 years or so since we did this. So after renal artery angioplasty, we see the patient back in the office for a duplex ultrasound, a creatinine, and an office visit within a week or two. We then do a renal artery ultrasound, a creatinine blood test, and an office visit every 6 months for 24 months, because that's when intimal hyperplasia is most likely to happen. And then we do it once a year. If we see evidence of restenosis on ultrasound, but the blood pressure is normal, we continue to monitor. If the blood pressure is elevated, we re-intervene. This is Heather Gornick's slide, and somebody put a stent in the entire renal artery. So when the kidney goes up and down, it goes up and down and it rotates. It puts enormous stress on the part of the stent that's here, and there's actually a stent fracture. These are multiple stents. And this is what you don't want to do, because if the patient has to go to surgery, then you have nowhere to plug the bypass into, and you've really jeopardized the kidney on this side. So this is the wrong thing to do with the patient. Now, a patient came to see me from Seattle, and many of you think FMD is an incurable disease. This patient didn't think so. She had a very severe stenosis of a branch renal artery with really severe hypertension. And we took care of this. Her blood pressure has been cured since 2018. She sent me this very nice vase. So thank you very much.